So when we have a younger person who is childbearing potential, and if they have a diagnosis of osteoporosis, we really need to ask ourselves, why do they have osteoporosis? Remember, in younger people under the age of 50 or in a premenopausal woman, we cannot make the diagnosis of osteoporosis purely on the basis of the bone density test. We need to have confirmation that there is impaired bone strength, and that confirmation requires a fragility fracture. So if your patient has not had a fragility fracture, they don't have osteoporosis. So in a younger person who is of childbearing potential and they are premenopausal, they're eugonadal, the first thing we're going to ask ourselves is, are they truly eugonadal? So if we have a patient who has a diagnosis of osteoporosis because they've had a fragility fracture, not just on the basis of a bone density test, then we ask ourselves, why do they have osteoporosis? Do they have a disease that's causing osteoporosis? And then we're going to go through all those conditions that we talked about. Have they been on medication that could have caused osteoporosis? Steroids, anticonvulsants, androgen, well, in women, we're looking at aromatase inhibition. Were they on Depo-Provera for long time periods? SSRIs, SNRIs over a long time period may also be associated with an increased risk of fracture. Do they have diabetes? Do they have kidney disease? Do they have cancer? What is the cause for their osteoporosis? And then we're going to take a very clear-cut history, because they may have not just a disease that's causing their osteoporosis, they may have an underlying condition that is affecting their skeleton, such as osteogenesis imperfecta. And osteogenesis imperfecta is associated with the mutation in the COL1A1 and the 1A2 genes. And we can confirm this diagnosis and get a molecular diagnosis by doing DNA analysis, but we look at the clinical features in our patients. Do they have blue-gray sclerae? Do they have hearing impairment? Do they have dentinogenesis imperfecta? Do they have joint laxity? Do they have easy bruisability? Do they have a family history of fragility fractures from young age, from childhood, or in the young childhood or teenage years? So we need to evaluate our patient's history carefully and look for other skeletal conditions. Do they have XLH? Do they have a low phosphate level? Do they have bowing of their legs? So patients who have XLH have a loss of phosphate through the kidney, and it's because of elevations in FGF23, fibroblast growth factor 23. And patients with the XLH can have bowing of their lower extremities. They have short standing height. They can also have dental problems with a periodontal disease, and they can have dental abscesses. They can also develop arthritis because the cartilage that is being laid down is not normal. They can also have hearing impairment. And so it's important for us to evaluate all these features and look at their phosphate levels, look at the urine phosphate, calculate the TMP-GFR, and then we would treat their underlying XLH. And so the treatment for a patient who has osteoporosis and is in the reproductive age group is based on, why do they have osteoporosis? Do they have hypophosphatasia? Hypophosphatasia is associated with reductions in alkaline phosphatase, and the reductions in alkaline phosphatase result in inorganic pyrophosphate accumulating, and that prevents the bone from mineralizing. And these patients can develop pseudofractures. They can present with atypical femoral fractures in young age groups. And patients with hypophosphatasia can have early loss of teeth, and the whole tooth can come out with the root intact. And they also have a myopathy, which is really quite striking. So the important point to remember is, don't think about which drug am I going to give my patient who has childbearing age osteoporosis. Ask, why does my patient have osteoporosis? Do a very careful history and physical. Make sure they don't have a disease that could be causing the osteoporosis. Make sure they don't have an underlying skeletal condition that is associated with impaired bone strength. And then obviously our treatment is going to be based on what we find. So with XLH, we're going to give our patient phosphate and calcitriol, and now we can treat our patient with burosumab. If they have hypophosphatasia, we're going to be able to treat them with aspartase alpha, because now we have definitive therapy for these patients, and we're going to avoid bisphosphonates, which would impair the bone mineralization further. If they have osteogenesis imperfecta, we might give them IV bisphosphonate, we might give them teriparatide. If they have steroid-induced osteoporosis, then we could give them bisphosphonates, we could give them denosumab, we could give them teriparatide. So the treatment will depend on the cause. If the cause was malabsorption, treat their malabsorption. Put them on a gluten-free diet if they have celiac disease, and you'll find the bone density is going to go up in leaps and bounds. So the key in this patient population is evaluate, 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 and find out the underlying diagnosis.